what they have shown that the patient, they have tried two different ways to detect the CTCs, EPS spot and the cell search method. Cell search, you may be aware, that is a FDA approved method. The range of the circulating tumor cells known 1 to 41, and you could see 3 to 37. And out of 5310 patients, so 18.9%, and the other method shows 11.3%. And very interesting case that after 3 years of the follow-up, none of these patients have been diagnosed with the colorectal cancer or any other epithelial cancer. So my question to Dr. Govind Babu, sir, is this a specificity issue? And we have been working in this area, and I remember you keep asking me that what is something that specificity we identify when we are culturing these cells.
Yeah, I think what you have shown is clearly a follow-up of 3 years and showing that in spite of so many CTCs being detected, none of them produced or developed cancer. So I think probably it's to do something with the methodology. So what we think is a circulating tumor cell may not be circulating tumor cell. So what our idea of it and how we are detecting it may be wrong. So that's how I see it. Or the other one is that there are tumor cells being shed, but your immune system is so strong that it's taking care of all this.
But then, don't you think that it could also validate it for the ctDNA, because the DNA is coming from the tumor cells?
Correct. So I think, I always keep telling my junior colleagues that we have such sensitive assays today that if you test in everybody, you will not find anybody normal on this planet. So that's how strong our methodologies are to be.
A very quick comment from Keith.
Well, I actually second the point that methods for identification of circulating tumor cells, I think, are still evolving, and important to emphasize that they are rare cells. And so, Aparna mentioned the starting point for analysis of circulating tumor DNA being 10 cc's of blood, and that has been the starting point for research methods in search of circulating tumor cells. But they are sufficiently rare that 10 cc's of blood is more often than not insufficient for patients with known cancer diagnoses, even metastatic disease. So there's been a movement in the research domain to try to obtain larger volumes of blood, 50 cc's for rhesus of patients, which is not to be done lightly, and then certainly not in routine clinical practice. I'm just trying to highlight the fact that I think they've not reached the point yet where we can have confidence that we can obtain with sufficient reliability circulating tumor cells and a population of those, that we can actually have some confidence in the molecular features of them. That's a little bit more of a sensitivity comment than your specificity concern. But I think the specificity issue is the first and foremost, you have to know that with confidence you have a malignant cell on your hands. And if you're making that determination based on a single cell, that can be certainly challenging. And CD45 combined with a set of care, and certainly alone is not sufficient to have that confidence. So not to be a naysayer, because I rarely am a naysayer when talking about promising technologies, I would put circulating tumor cells perhaps a position behind circulating tumor DNA in terms of what information we're able to read out currently and issues of both sensitivity and specificity. But would never suggest that research stop in any domain. I think we have a problem of rarity of cells and we need to try to further develop methods for capturing them.
Thank you.
Great, thanks, great comments, and fantastic insights into liquid biopsy. So for the larger crowd, when we do diagnostics, especially when we are talking about precision diagnostics, we are talking about tissue testing. That's what the first slide was about. Then we deliberated on liquid biopsies, which is the blood-based testing. And in that we have circulating tumor DNA, we have circulating tumor cells, and we talked about the nuances of that and what to test and what not to test and what's ready for prime time, etc. Yesterday we were in a meeting where we discussed, the first slide was presented by Dr. Keith Flaherty, I say the king of precision oncology, he presented a slide where 40% of the cancers had a target and 60% was black in that pie chart. So what is that black? 40% has targets. So you give immunotherapy, you give targeted therapy. I'm more concerned about the black. What does the world do with the black? The black, 60% of the pie, what do we do with that? We give chemotherapy. So, my question, and we can go to the next slide, my question to Dr. Nabil is regarding testing outside of the patient, testing in organoids, and how is the field positioned at this time? Because we have somewhere to stop experimenting on our patients. We have to somewhere test outside and be able to bring the information back. Are we ready for prime time?
So I think again, this one? Yes.
Yes,
So I think
okay.
again, this is one of the examples of a technology that's there, but it's not fully validated for almost any application, but that a context such as cancer in India might offer opportunities for much more rapid validation, where a uniform cancer type can be used with a uniform or a set of different types of these personalized functional precision medicine techniques, whether it's organoids, short-term cultures, organotypic cultures, and so on, where large enough group of patients with similar genomic features and exactly the same cancer type can be rapidly put through a test where the functional precision medicine gives a prediction, and the patients can be treated along those lines with suitable speed and suitable uniformity to get a definitive answer in one context. The answer is likely that each cancer type might benefit from a different type of assay system. So you mentioned organoids here. Organoids, as used by most of the field, involves a very artificial type of culture condition that clearly can reprogram the cell. The advantage is that you get very robust growth in a lot of cases, but this might indeed favor a reprogramming of the cell to some extent. So I don't think there's going to be a likely one-size-fits-all. So I would say this area is evolving rapidly, and this community here can make a very large impact on the field for the whole world, I believe.
Thank you. We are actually waiting for more to happen. And so for a quick vote here amongst all the practicing oncologists, is anyone doing chemosensitivity analysis?
So actually some years ago we did a project, and this was a large cohort. For a test like this, it is a large cohort of almost 100 head and neck cancer patients, and this we published in 2018 in Nature Communications. So this was sort of a validation study, and we did show that it was possible. So the largest cohort we did